Thank you very much for choosing to watch this video on lower limb joint pain, particularly osteoarthritis. We normally carry out these sessions once a month in a group setting in Grangemouth, Stirling and Clackmannanshire. But unfortunately, due to coronavirus, we're unable to do this just now, and when the groups do return, they probably will be limited in number. So we thought we'd bring the presentation online, and it'll stay online as well, so that people can watch from their own home. And we'll still invite questions through a specific email address, a specific mailbox that we've set up. So if you have any questions through the process, then you can get in touch. What we're hoping is this presentation explains an awful lot of things that you might be wondering about in terms of your joint pain, symptoms, how you can help yourself, things like that. And we really want to focus on osteoarthritis. However, a lot of the advice carries over to things like cartilage problems as well. So hope you find it very useful and hope it answers a lot of the questions that you might have. So just a quick bit of background. My name is Peter Reid and I'm an advanced physiotherapy practitioner and I work in GP practice. There's a wider team of advanced practitioners who work across many of the practices in Forth Valley now. And our role was introduced because the GP surgeries are getting busier and busier, and it was recognised that physios and other health professionals could actually move into practice and see an awful lot of patients who would benefit from our expertise immediately, rather than sitting people on a waiting list for a long period of time to get pretty much the same information and input. So our aim is that our patients see the right practitioner at the right time. And unfortunately, there's been many cases in the past where patients may have waited several months to see a particular person, whether it be a physio or a surgeon, only then to be referred on to someone else because actually that person wasn't the right person to see them at that time. And while they've been referred to someone else, they're having to wait even longer to then see that person. So we want people to have all the information that they need so that unnecessary waiting is a thing of the past. And how does that help with your lower limb joint pain? Well, for far too long, there's been a variation in how we get information to people. So some people might see a physio, some people might see an orthopedic surgeon, or in quite a lot of cases, actually, people struggle along without really seeing anyone. And we don't want this to be the case. So we've created these sessions so that anyone with lower limb joint pain or their relatives, anyone at all, can get access to this information so that they can understand the condition better. We want to reduce the variation that people experience and ensure that everyone is informed and receives the kind of first steps on how to manage that condition. So the aim of the sessions, the group sessions that we ran in person, but also this session, is to help improve your understanding of common knee and hip problems like osteoarthritis, as we've said before. Learn about the things that influence the pain in your joints, because that's very important if we're trying to figure out how we get rid of the pain. If we don't know the things that annoy the joints, then it's very difficult to manage that. So we try and explore that. We want to learn, or hopefully, kind of show you how you can learn to self-manage, and that's really important because arthritis is a long-term condition. It's not often seen as a serious one, but it can be sore and it can be debilitating. So knowing how to self-manage it confidently is one of the major steps in trying to get over your pain and discomfort. And we want you to learn about your options as well. So it would be remiss of us to say just because you've watched this session, you won't need any help from anyone in the future. We know that's not true, and we know that a lot of the time support is needed, maybe not immediately, but months or years down the line, and that's not closed to you, and we run over what support is available to you within NHS Forth Valley. So if you do have any questions after watching this presentation, please feel free to email this rather long email address below, and we'll strive to get back in touch with you as quickly as possible. If you're already seeing your GP or you have a physio appointment, for example, then please ask questions of them if you go as well. But if you're watching this and you maybe haven't had any input from anyone, your doctor or surgeon or physio, then hopefully you find this session really useful because it will probably answer a lot of questions you may have. Always remember as well that because this presentation is online, you can pause it. So if I'm going too fast through the slides, and please feel free to pause and read them as well. But hopefully I don't do that. We'll start with the big question then. So what is osteoarthritis? I think as health professionals, quite often we presume people know what arthritis is, almost without asking them. So we know that's not right. We should never do that, because there'll be plenty of people out there who actually don't know what's going on inside their joint, and therefore we can't really expect them to know how to cope with the pain and how to exercise to improve things. So we'll start with the very basics. So osteoarthritis doesn't help. First of all, it has lots of different names and things that we call it. So some people know it as arthritis, osteoarthritis, OA is what we abbreviate it to in kind of healthcare settings. Degenerative change, wear and tear, and effectively they all mean pretty much the same thing. So osteoarthritis is a process where the cartilage that lines the joints can degenerate over time or sometimes through injury. So if you get damage done to the joint, it can make arthritic change happen quicker. And the changes in the joint lead to inflammation, some swelling, and then over time the bones can become a bit rough and the bony structure of the joint can change. And this can lead to pain in some cases, but not always. There's a lot of people over the age of 45 who may have some signs of arthritis, osteoarthritis, on an X-ray, but actually they're not in any pain at all, and they don't have any stiffness at all. So pain isn't inevitable. And neither is arthritis, actually, I should mention. There are some people who might be in their 60s, 70s, 80s even, who if you x-rayed their knees, hands, back, would show no signs of arthritis. But it's most common over the age of about 45. That's normally when if you x-rayed someone's joints, they would start showing little signs of it. But as I say, not always. In some cases, it can occur earlier as well. So there are some people who are under the age of 45, maybe mid to late 30s, who get early arthritic change. It's quite rare, but it can happen. And it can also occur in any joints in the body, really, but the main ones that kind of bear load and support us and work hard, like your lower back, thumbs, toes, things like that, and obviously the knees and hips and the leg, they're the joints that commonly get arthritic change. So if we look a little bit deeper into the role of the cartilage in an arthritic joint, it's heavily involved in arthritic change, and usually the wearing of the cartilage is what causes the symptoms in your knee or hip to come on. So knees and hips are slightly different to some joints because they have different types of cartilage within them, whereas a lot of joints just have the cartilage that lines the bones. So the different types of cartilage in the knee and the hip perform different functions. So it's useful to go through the different types of cartilage and what they do, because this can help explain some of the symptoms that we find commonly in the joints, but also helps to explain why some people with apparently normal x-rays can still suffer a lot of pain. So the knee, if we start with it, has two different types of cartilage. You've got articular cartilage that lines the ends of the bones, so the ends of the femur, the thigh bone, and the end of the tibia, the shin bone. And you can see it on the picture here, it's the kind of shiny blue surface on the front of the picture. The other type of cartilage is the meniscus. Now, the meniscus is a wedge of cartilage that's attached to the top of the shin bone, the tibia, and its job is to cushion the joint during weight-bearing activity, but it also distributes force and load. So when you're kind of walking or running, the meniscus is cushioning the thigh bone as it comes down and makes contact with the shin bone. Now, arthritic change would normally be diagnosed when the articular shiny cartilage is wearing and the kind of bony change is apparent on x-ray. However, x-rays aren't normally able to pick up problems with the meniscus because the x-ray goes straight through soft tissue and doesn't actually see it. So that's why if you've got damage to the meniscus or tears in the meniscus, if that's your symptomatic area, quite often an x-ray won't identify that, but you can still be in pain. If we move on to the hip joint now, similarly to the knee, it has two different types of cartilage. So you've got the articular cartilage that we mentioned before in the knee. It happens in the hip as well. And we've got the labrum. So the articular cartilage this time lines the ball at the end of your thigh bone, your femur, and it also lines part of the socket called your acetabulum. Just like the knee, the articular cartilage allows the ball to kind of glide in the socket, and it's when this shiny cartilage becomes worn and starts to get a bit rough that we get friction, pain, and sometimes restriction in movement. And again, it's on x-ray that you're likely to find signs of arthritis being caused by this articular cartilage having issues. Again, just like we said in the previous couple of slides, if you have wearing of the articular cartilage in the hip, many people don't get pain from it at all. So it's usually only when it's particularly inflamed and irritable that you start to get pain. Now, the labrum, as we said, is the other type of cartilage. Now, it forms an extension to the socket, if you like, and the socket is in our pelvis. And this labrum acts like almost like a sucker to keep the ball securely in the joint and to prevent things like dislocation of your hip. It also provides cushioning, just like the meniscus does, when you're doing things like walking or higher impact activity. Now, of course, just like the meniscus, the labrum can also suffer from tears or imperfections. And they are actually fairly common as we get older, but they can still cause pain that might not be identified with an X-ray. So this slide demonstrates how your joints can change with osteoarthritis. It doesn't always happen like this, but this is the most common pattern that we would expect to see. And some of the symptoms in the little pattern below you might be familiar with. So as the cartilage that lines the ends of the bones becomes a bit thinner and a bit rough, and as the wedge of cartilage, like the meniscus in the knee we were just talking about, as that becomes a bit thinner, the bones at the end can become a bit thickened, rough, and bony offshoots can start to form. We call them bony spurs. And these little bony spurs can be kind of sharpened edges, if you like, and they can irritate and annoy some of the soft tissue that surrounds the joint. So the most common one, again, would be the knee, where some of the ligaments that surround the knee maybe become inflamed because you've got this kind of sharper offshoots of bone there. And a very common symptom in arthritis is then when the joints start to swell, because as they're irritable and as they inflame, they'll produce fluid. So that fluid will cause the joint to swell up. And in turn, that causes the joints to become stiffer because they can no longer move the same way they did before because of the amount of fluid that's inside them. When joints are stiff, muscles get weak because actually they can't carry out their normal function. Because if you don't have full movement of the joint, then you're not utilizing the muscle the same way you would if it didn't have any stiffness or swelling. And this pattern kind of goes round and round and can get worse actually over time if it's not tackled. And that's why it's very important to say that actually there's things that we can do to interrupt this cycle. If we strengthen the muscles and maintain the flexibility in the joints, then you can actually slow down or change this pattern. And there's a section later on how to help that will show you ideas, hints and tips about how to go about that as well. So how do we diagnose osteoarthritis? Well, as physiotherapists and health professionals, we use the NICE guidelines, which is a set of guidelines that follow all the research and follow what it finds and what it says. So it means that there's a few different points that we can follow to almost presume that it's osteoarthritis in the absence of other symptoms. So those NICE guidelines say that if the person's over 45, if they wake with stiffness in the morning but it goes away within sort of 30 minutes to an hour, and the pain's more activity related, particularly in the latter stages of the problem, then it's most likely to be osteoarthritis rather than other issues. Whereas if the person had a big red swollen knee, hot to touch, that would be less likely to be an arthritis. So we can make these presumptions based on your symptoms. However, the most common way, I suppose, that we would diagnose osteoarthritis, frequently used by GPs, consultants, and ourselves as physiotherapists, would be to X-ray the joint. We sometimes have to be a bit careful because X-rays of the joints don't show everything. They don't show soft tissue, for example. So if it is a cartilage problem in the main, like the wedge of cartilage in the knee, for example, the X-ray won't show that wedge of cartilage, so it doesn't really give us all the information. All it shows is the condition of the bone, and often that's enough to kind of grade the severity of the problem, and that's what a surgeon would be interested in, for example, if they were thinking about operating. But we do need to be careful because in the past I've X-rayed people and they might appear to have mild arthritis on an X-ray, but actually their pain's quite severe. But then I've also seen the other way around, where you can have quite severe changes on X-ray, but the person's in relatively little pain, and so they probably don't need any major intervention at that point. So X-ray is very useful, but we don't always need them. And in physiotherapy especially, we're more interested in the story, the general picture for that person. So how's the pain affecting their hobbies, their job, how are they generally getting on? So we use a variety of different bits of information to try and help rather than just an x-ray, for example. So this slide covers what makes osteoarthritis more likely. And just below here, we've got 6 main contributing factors, and there may be more ones kind of in and around this, but these are the main ones that we've kind of found over the years to be the most likely to contribute to osteoarthritis. So if we start at the top, we've got age. Over 45, as we've discussed before on the previous slides, makes you more likely to get arthritis. But as we also said, you can get arthritis significantly younger. And when that happens, we would probably then skip down to the bottom factor here in genetics. So they used to say that wear and tear arthritis or osteoarthritis didn't necessarily run in families, but I think now we're starting to change our tune on that. Instead of it just being kind of rheumatoid arthritis and ones like that, I think we now recognise that if you're in your 30s and you're already developing osteoarthritis, there's a very good chance that the same thing happened with your parents and your grandparents and your great-grandparents, in which case there's also a high likelihood that it does run in families. So although that's not dead cert and it's certainly not a given, we now realise that it probably can run in families, particularly for the people who suffer at a younger age. But that almost makes it more important to exercise and to strengthen the joints and maintain their health, because just because you're predisposed to it doesn't mean it will happen. But on the odd chance it does happen and you do develop arthritis at a younger age, if you've got strong joints and good muscular balance round about the joints, then the chances are any arthritic change you suffer isn't going to make as big a difference as it would if you didn't have that preparation. If we then move on to the middle one there, we've got gender. So women are twice as likely as men to develop arthritis, or almost twice as likely as men. So it's quite an interesting fact that. If we shift focus a little bit now, and we go into weight now, weight is quite an important topic to cover, and it's quite a sensitive one to cover as well. A lot of people don't like talking about their weight, and we don't mention it here from a judgmental point of view. It's only informative, and I think it's important to point out why weight can have such an impact on the bones and the joints. So even being underweight can cause a problem. So if you're underweight and you don't get enough nutrients and minerals, then things like osteoporosis can develop, which is a problem where your bones become too thin and they become a bit fragile. And if that happens, then if you fall or have an accident, you can suffer damage to the bones that way. But being overweight is certainly a high risk factor for developing osteoarthritis. And the basis in it comes from the fact that the joints are carrying more weight than they expected to. So if you think about the skeleton, it's designed to put up with a certain amount of weight depending what height you are. But if you're overweight or significantly overweight, then you're going to put a lot more strain through the joints, and that in turn can cause irritation and can cause pain. There's also a lot of really good new evidence out now to suggest that people with slightly poorer diets, or who are overweight because their diets maybe aren't varied, or they maybe just eat that little bit too much, they can carry a lot of inflammation throughout the body, so not just in the joints. So their gut can be quite inflamed, and they reckon there's quite a close link between the chemicals that are produced with this inflammation in the gut and joint pain. So actually they reckon that losing weight won't just help to take the pressure off the joints, but can actually affect the way we perceive the pain. Because if these chemicals are coming down and reducing, then they're not irritating the joints in the same way. Another bit of evidence as well is where we carry our weight can also have an impact. So they've done a lot of studies on weight, as I said before, and they think that carrying more weight around your abdomen, around your midriff, can make it more likely that you'll get joint pain. But it's actually also one of the first areas that we lose weight from. So if we flip it on its head, there's a positive there as well. But one interesting fact that came out, just to kind of summarise the weight part of the kind of topic here, is that through research they found out that for every pound or kilo or stone, whatever measure you use, but for every single measure of those weights that you put on, so let's just use a stone as an example. For every stone that you put on, the joints feel as though you're carrying 4 times that. And obviously you're not carrying 4 stone if you've just put a stone on, but the joints perceive it to be more because they're having to hold you up and you're weighing an extra stone plus gravity kind of pushing you down, so the force increases through the knee, so it feels like it's carrying a lot more. But the great thing is, taking weight off will also divide the amount that the knees feel. So if you take a stone off and you lose a stone over a period of time, then your joints no longer feel as though they're carrying that stone. In fact, they'll probably feel 4 stone lighter. So although it's important that we focus on weight and we don't ignore it as a contributing factor, it's also important to point out that reversing it and reducing weight can have such a positive effect on joint pain, and that's why we mention it. If we move on to occupation, there's certain occupations that make you more likely to get arthritis, and you'll probably know which ones I'm going to say. Things like carpet fitting, joinery, being an electrician, working on the knees regularly. Interestingly, people with sedentary occupations or desk-based occupations are also more likely to get arthritis, and we link that to the fact that because they're not as active, the muscle tone around the joints probably isn't as good, and therefore the joints are open to greater forces to then kind of irritate them over time. And they did a very interesting study between desk workers and marathon runners, and you would think marathon runners would have dodgy joints because they run 26 miles in one go, but actually they found that although both groups get arthritis, the marathon runners on the whole were less likely to get arthritis than the desk workers. So it shows the importance of using the body and using it well, albeit not having to run marathons, but strengthening and keeping the body fit. The last topic I think it's really important to go over, injury or surgery. Now, the reason why these two contribute, they kind of interlink, but for different reasons. So injury, let's say in the knee again, if we use it as an example, you tore your cartilage or tore one of the ligaments in the knee. That then affects the way the joint works. So if you get the cartilage fixed, for example, when they do a cartilage repair, quite often they trim little bits away from the cartilage, and that's no longer there. So they've taken some of the cushion away from the knee that you no longer have, and so you're then weight bearing on less cushion and then more likely to go through that cushion quicker over time, if that makes sense. So injuring a joint can make it more susceptible to then developing arthritis later in life, although it's absolutely not dead cert. It's one of these things that's more likely, but doesn't mean it's definitely going to happen. And the last one we talk about is surgery. So quite often people ask me whether or not they're suitable to go for surgery, and quite often we have to end up saying to them, well, actually we haven't tried a lot of different things first. And the reason why we don't jump into surgery is because actually a lot of the time it isn't particularly useful for pain. Now obviously there's clear cases where that isn't a correct statement. If you have severe arthritic change and you get a knee replacement, then the knee replacement can significantly help your pain. But there are operations like the arthroscopic washout surgeries, the keyhole surgeries. They used to do them quite a lot, and then recently the numbers have dropped because a research paper came out to say that actually these surgeries didn't always help with people's pain, and that was one of the main reasons why we did them. But these surgeries can make you more likely to get arthritis, because every time we open someone up and we change the joint in any way, we're technically making them more susceptible to getting changes in the joint. So that's why we have to be careful with surgery, that we only do it on the right people at the right time to ensure that we're not causing any unnecessary change in a joint. So just at the back of that slide, talking about surgery, it's interesting actually, our orthopaedic surgeons here in NHS Forth Valley now very much have the approach of wanting to optimise our patients and make sure they're as strong, fit and healthy as possible before they potentially have to go through an operation. So one of our surgeons here, Mr. Ian McLean, has developed a leaflet that will be available on the NHS Forth Valley website for anyone to see whether they have an appointment with orthopaedics or not, and it's called Feel Better, Heal Better. And it's aimed at people with lower limb joint arthritis who may or may not be considering surgery, but are considering referral to orthopedics. And inside the leaflet, there's lots and lots of ideas and resource on how to manage various aspects of your health that contribute to the arthritis and how to manage the lower limb arthritis well. And they've all been identified by the surgeons here as good resources to make a start on self-management. And the plan is to manage your joint pain without the need for surgery if possible, um, to optimize the body and get ready for surgery if it turns out that that is actually what's needed, and then to prepare well beforehand so you make a good recovery if you do need surgery. So the optimizing the patient can come under any of those categories, but the Feel Better, Heal Better leaflet could be a very useful resource to give you ideas of how to achieve that. Um, the orthopedic doctors would like to prepare patients various aspects of their general health rather than leaving the recovery to chance. And as a result, they want it to be widely available. So if you have a wee look at the link below, you can download the leaflet developed by Mr. McLean. So the symptoms, well, if you're watching this video because you have sore hips and knees and you have arthritic change, then you'll be more than aware of the symptoms. But to run through them, pain is clearly the most common one that people come to us with. So it usually is these sharp episodes when you maybe twist the knee, for example, followed by that dull, toothache pain that often goes away with gentle movement, but gets worse if you overdo it. Sometimes gets worse when you're sitting for too long and it gets stiff. Stiffness itself is quite a common symptom, so it usually gets better once you start moving around and once you start going. But if you go too far or you go over your limit, then sometimes the stiffness can cause some swelling. Swelling usually isn't hot in knees, so it can feel warm, but usually if you've got like a bright red knee and it's red hot to touch, we would suggest you go and see your doctor about that because it might be something else actually, so that's usually a wee bit of caution there. But generalized kind of not hot or warm swelling isn't usually an issue, it's because the joint's irritable. Crepitus is the noise that knees make, particularly knees. It does happen in lots of other joints, but the knees are the ones that get the kind of grating, crunching, grinding, especially under the kneecap. Um, Crepitus sounds awful sometimes, but it's usually not harmful at all. And a lot of the time, the crepitus is actually relatively pain-free, so it's not a big issue. The noise is just more off-putting than anything. If you've got crepitus and that grating and grinding that comes with an awful lot of pain, it might be because the undersurface of the kneecap is quite worn and sore as well. But in a lot of people, that isn't the case. The kneecap's actually not too bad. It's the weight-bearing portion of the joint. So I think it's sometimes really useful as well to go through where the symptoms are most common. Obviously today we're particularly focusing on knees and hips because it helps you understand probably what the most symptomatic area of the joint is for you. So in the knee joint, you can effectively can get pain anywhere in the knee if it's arthritic, but the most common place where you would feel the pain is the inside of the knee, where the two bones meet. We call it the joint line, so the kind of inner aspect, and that's sometimes why if you're falling asleep at night time and your knees are touching, you get kind of discomfort. It's also why sometimes when you're standing and you twist the knee, that the pain can then shoot into the inside of the knee because that's usually where the most worn parts are. But you can also get pain under the kneecap as well. So when it's flaring up under the kneecap, things like going up and down stairs can be quite tough, or kneeling on the knee can be particularly sore as well. And we normally feel the kneecap related pain on the front of the knee actually, rather than the kind of inside of the knee. If your knee's quite swollen, it can sometimes cause swelling to leak into the back of the knee. So some people get posterior knee pain or pain in the kind of soft bit behind the knee. And again, that's usually because the swelling's occupying some space and irritating the soft tissue in there. Some people can develop what we call a Baker's cyst, which is a fluid-filled pouch, if you like, that kind of flares up when the knee's swollen, but then tends to settle down once the knee settles down. So the knee's got lots of different areas that can be sore, and there's normally very kind of explainable reasons why that would be the case. The hip joint is slightly different and sometimes catches people off guard. So when we get people in with hip pain, they normally say it's not my hips because they're almost pointing to the side of their hips, like where their thighs are. Because a lot of people actually think that their hip joint is near the side of the thigh, but actually the hip joint's a lot closer to your groin. because the ball in the socket it's more towards the front, around where the groin is. And so actually the most common type of hip joint pain is actually groin pain or deep buttock pain rather than being the side of your leg. And it's fairly regular for hip joint pain to refer down your thigh as well, usually the front of the thigh, especially if the pain's getting worse. So we tend to find the more sore the pain is, sometimes the further it travels. The knee can also refer pain as well, by the way. It can sometimes go down your shin. So people will come into us and say it's my shin that's really sore, but actually it's coming from the joint in the knee. So hopefully that gives you a little bit of background as to where the most common sites of the pains in knees and hips come on. So how does pain work with osteoarthritis? Well, most patients with osteoarthritis will complain of the pain flaring up and then settling down. So there's not many people that have it 24/7 every single day, but it can commonly and frequently come on and off depending on what the person's done. So these painful episodes happen usually when we do something that the joint wasn't prepared for and maybe wasn't happy to do. So the best example for knees is things like kneeling for too long, kind of crouching down and twisting the knee and then getting that kind of sharp pain in the inside. For hips, it's usually things like getting out of the car the wrong way, again, or turning the whole leg the wrong way and getting a pain kind of in the groin and in the buttock. So sometimes flare-ups can be almost the simplest things, but actually sometimes it can be maybe we've just pushed the joint a little bit too far too soon. So some people when they start their exercise journey, for example, will try and do too much actually. So they might go out for a jog rather than a walk, and then the knee just doesn't thank them for it, wasn't particularly happy about it. And it doesn't mean they'll never be able to do that activity. It usually just means that we need to build up to that. So flare-ups kind of they get worse and then they settle. If they get a bit out of control and the knees and the hips aren't strong enough, then the flare-ups can come on more often, and that's really what we try and stop. So, how can we help manage pain caused by flare-ups? Well, sometimes just an understanding what's going on inside the joint can help. Knowing that the pain that you're experiencing rarely means damage is a huge help in itself. So quite often people are worried that when they're getting soreness in the knee or the hip and it's constantly happening, that they're doing more harm than good. When actually what it's telling us is that the joint's getting irritated on a regular basis and we need to look at how we reduce that. So understanding that's very useful. Another thing that's useful to know is the frequency of the flare-ups. So they normally only last a few days to a few weeks. The worst ones can sometimes last a couple of months if they're not managed very well, but they can be settled with the right steps and the pain can come down. So it's important that we realise that we can help by accessing appropriate pain relief, for example, to try and reduce the flare-ups. Now, strengthening the joints and leading a healthy lifestyle, there's a point that's probably the most significant one we'll come across. Because getting the muscles nice and strong round about the joints and generally keeping the body as healthy as we can is known to significantly reduce the number of flare-ups we get, but also how sore they are. So that's another way we can help, and that's not an immediate thing. That's something that would take a little bit of time to strengthen the muscles and work on your general health, but it's not insurmountable. It's something that really, with the right guidance and the right assistance, and hopefully this video provides that, then you should be able to do. So what about pain? Pain's a very complicated topic, and actually you could probably do a whole course for a week or more on pain because of the various ins and outs. So it would be wrong for us to try and squish that into a couple of minutes in a slideshow. But I think it is important to talk about it at a very general level, so that you might start to understand and kind of think, well, that might be why I'm sore actually, and maybe it'll make a bit more sense once we go through it in these next few slides. Pain is the most common symptom, as we've said before, with osteoarthritis, and it's the number one cause that brings people to seek help from myself or a GP or an orthopedic surgeon. So what actually is pain? So what's the textbook definition of pain? Well, it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. That's an interesting statement straight away, really, because it's saying that pain can come on with actual injury, so something like tearing a calf muscle or falling and landing directly on your sore knee, but it can also come on with when the body suspects potential tissue damage. So the body's clever enough to try and defend itself if it thinks it's getting sore. So that would kind of back up our theory earlier on that, pain doesn't always equal damage. Sometimes if you just do too much, if you crouch or twist or irritate the knee, then pain will come on as the body's way of saying, just watch out. So it's interesting to see that, and hopefully that clears up a little bit about what's going on. So yeah, of course we can get pain through injury, but sometimes we can get pain despite the fact there's no injury. Sometimes it's just annoyance, irritation. And there's different types of pain. So there's acute pain and there's chronic pain. So if we start with acute pain is typically short-lasting, resolves within 3 months usually, and it's kind of in line with the body's repair process. So if we use the calf muscle tear as the example here, you've injured the calf, you've torn the muscle, and over the weeks and couple of months after that, it will repair properly, and you'll likely go back to normal. So we expect that an acute pain kind of goes away relatively quickly. Chronic pain is the one that actually, with arthritis in a joint, you probably suffer more of if it's not very well controlled. So chronic pain is pain that doesn't resolve within that typical healing time scale that the body has. And it can be quite unpredictable, and it can come on at different times for different reasons. So that makes it more complex. If we think about chronic pain, because it doesn't follow the time scales, normally the initial injury you did, so if we use the one that we had before, falling onto the knee joint that's already arthritic, it could be months and months down the line, and actually that fall, the effects of that fall will have gone away. So if there was any damage done, it will have repaired itself just like the acute pain does. But chronic pain's different in that the body just doesn't seem to recognise that it shouldn't be sore anymore. And that can be for a variety of reasons. It might be that actually the joint's not strong enough, and so you had the initial injury, and although the injury's healed, the irritation carries on and on and on, and that in turn carries the pain on and on. So it kind of backs up the statement again that, pain doesn't always equal damage. Sometimes it's longer term irritation. But probably another one of the most unfair sides of chronic pain is that the little nerve endings that give us the pain, we actually know through research that the longer we have the pain for, the more sensitive they become. So actually they start to pick up pain more easily with less input. So like we said right at the very beginning, sometimes people who used to be able to walk for miles 6 months ago or 9 months ago, they might not feel anything's changed much in their life, but if the pain's there for long periods, all of a sudden they can barely walk for a couple of minutes without discomfort. So getting chronic pain under control is a really important part of recovering with an arthritic joint. So what else can affect the pain? It's very important that you know what the triggers are, because if we're talking about all this pain and it's caused by this, that, and the next thing, if you're experiencing lots of pain, particularly chronic pain, which is long lasting, if we don't know what triggers it, or we're not very controlled in knowing what triggers it, then that could be a huge issue, because we might be doing things that we don't know are making us worse, but they are. So the first thing that can affect the pain is physical deconditioning. So that's obviously where we're in physiotherapy, we're very interested, because we want to get the muscles toned up and strengthened and get your body working as good as it can. We know if you're physically less conditioned and your muscles are weaker, they'll not carry you very well. They'll allow the joints to put up with most of the pressure, and so your little pain receptors within the joints will fire off with no issue. If we change that and strengthen, then we can turn that on its head. Mental health, now this should never be underestimated, mental health. So if we go back to the previous slide about pain being a sensory and emotional experience, if you're emotionally not in a very good place, if you're upset, if you're depressed, if you feel low because you may have been stuck in the house for 2 weeks in pain, then our body releases chemicals that actually, and very unfairly, make us more sensitive to pain. So if you are low, then it's very important that if it's something that's been affecting you for a while, then you ask for advice. We've got some resource at the end of this slideshow, because if you can turn the tide on the mental health and improve your mental health a little bit, then those chemicals that heighten your experience to pain, they reduce in the body. So actually your pain can go down if you feel better. And sometimes the silly example I use is, imagine you've been on the phone to the bank because someone's hacked your account and taken all your money. Now that's a horribly stressful situation. Now imagine you're on the phone, but they've sent you over to the put you on hold for 30 minutes, and you're walking backwards and forwards, but you knock your elbow off the door, and you get this horrible kind of funny bone pain down the arm. That will probably feel 10 times worse because of the stressful environment you're in. If we flip it on its head and you're maybe in a nice environment, maybe you're at a party and it's New Year's and you've maybe slipped and fallen on your bum, how many times do you just get up and laugh because actually, the situation was amusing, and everyone around was having a good time, you were having a good time. So you don't experience pain the same way from when you're in a stressful environment compared to a non-stressful environment. So if we can reduce general stress and anxieties, then very often we can make you as a person generally feel better. Another thing that can affect the pain, fear of damage. We get this an awful lot where people maybe have been given the wrong terminology, or they've Googled something and it's talked about damage, damage, damage. The fear of damage often makes people avoid exercise, whereas exercise is exactly what we should be doing. And we don't need to run marathons. It's very simple stuff that I'll show you later on. But that fear of damage could be almost as bad as the problem itself, because it stops us from moving on. It stops us from moving forward. Lifestyle choices is the next one. So smoking, for example, is linked to poor body healing. So the chemicals in the cigarettes and the cigars, whatever you smoke, they can delay the healing process, and so they can make pain last longer. Poor diet, kind of links to weight, what we talked about earlier, but actually an interesting fact that not many people know is that if you have a poor diet, your body generally is a bit more inflamed. So processed foods and fatty foods, your body actually gets a bit swollen inside and inflamed and irritable from having the diet like that. And so what happens then is we get more inflammatory chemicals in the body, and these inflammatory chemicals that are in the body actually make us more susceptible to pain again. So there's lots of stuff that's kind of working against us in the background sometimes. So actually having a slightly better diet, you don't need to be perfect, but having a slightly better diet and maybe cutting out certain foods, or trying to cut them out some of the time, can make a huge difference to pain. Poor sleep is the next one. So if you don't sleep very well, then sleep is our repair time. That's when our body fixes itself and rests. So if you're having a bad sleep, or you've had a run of 2, 3 weeks where you've barely slept at night, you're going to feel worse, definitely. And the last one, health beliefs. So we more regularly than you would think have people coming into clinic thinking that their knees are crumbling, and that's why they can't walk in them, because they're frightened again, almost linking to that fear of damage. That health belief that their joints are going to crumble and break leads them to do very little. So, and actually that just makes things worse. So if we have the right beliefs and the right information, then that can make a huge difference. So this is the physical and psychological cycle with pain. Now this cycle here just shows the interaction between the physical aspects of pain and the psychological ones, so the ones that are happening almost without us knowing it. So just to very quickly run through, it kind of backs up what we've already said in the previous slides, but if you're psychologically not doing very well, you're maybe angry, sore, a bit afraid to exercise or afraid to do things, you'll have a lower mood, which could lead to kind of worsening things like depression, and that can increase your perception of the pain. What happens with that is that you maybe avoid activity, you get progressively weaker, and you get pain with a lot less activity, and that's very important. As I was saying right at the beginning, you're able to do less when you could have done that activity maybe 6 months ago. That leads you to avoid things further, because actually simpler things are harder now. And then you get more decongestioned and weaker again, and these cycles just interact very inconveniently, and so we want to try and interrupt the cycle if we can. So we've talked about pain, but how do we help manage pain? Well, the first thing we'll do is talk about pain relief. And it's important to note straight off the bat that not everyone wants to take painkillers, and it is a very personal choice. So if you're someone who doesn't want to take pain relief, then that's absolutely fine, and it's 100% your choice. Some people see it as a bit of a sign of failure that they've had to resort to tablets, and other people simply can't tolerate the side effects that come with painkillers. And there are a few, your anti-inflammatories, for example, can raise your blood pressure and can affect your kidney functions. So there might be certain percentage of the population who don't tolerate them. Other stronger medications like your opiate drugs have a lot of side effects, like drowsiness, can make you feel a bit sick. So side effects is another big reason why some people maybe wouldn't manage them. But for a large percentage of the population, they can be very effective if used over a short term and at the right time, and I think that's very important. So if we're talking about the benefits of painkillers, well, they could be a very beneficial way of managing flare-ups, and that's all we're interested in, really. So as I say, they're most beneficial when used over a short period, not a long period, and they control the pain so that you can do more. Okay, so what we're aiming for is to bring the pain level down and not necessarily make it go away completely, although that'd be desirable. But if we bring the pain level down, you can exercise more comfortably. We can do some rehabilitation work for the joints and the muscles round about them. And we can make you stronger, and then that should make you more resilient in the future, so that the next episode of pain you get will maybe be a lot milder, and then actually you might not need painkillers at all for that one. We always say for painkillers, you do need to speak to a pharmacist or a GP. If there's a physiotherapist or health professional, I don't really have the qualification to advise on drugs. That's really your GP and pharmacist domain, but we are still allowed to overview and highlight the benefits of them. So if we're giving the overview of the drugs and what benefits they have, then we often start with the pain relief pyramid. So that gives a bit of an idea about why we start certain drugs and don't just jump up to the strong ones. And it's all about how they react with you and to do with their side effects. The higher up the pyramid you go, the more side effects there are, whereas the lower down the pyramid you are, there's relatively few side effects. So if we start with paracetamol, it's readily available over the counter, relatively few side effects if you stick to the stated dose in the box, and so that's why it's at the bottom of the pyramid. It works for a lot of people as well, so there's no need to jump up to really strong medications if paracetamol works. We then move up to the gels and the rubs, so your ibuprofen rubs. They could be quite good to apply to an area to reduce local pain and inflammation there. Some people say they work really well, some people don't think they work, so it really is, again, kind of that personal choice to see what works for you. If neither of those options work, you're then moving on to anti-inflammatories, which are in the middle of the pyramid and mentioned before about their side effects. So they can affect things like blood pressure and kidneys, and that's why they're slightly higher up the pyramid. And they come in many forms. So you've got ibuprofen, diclofenac, naproxen, drugs like that. You can get some anti-inflammatory over the counter, but we would always recommend you speak to a pharmacist or a GP before you start, just in case there's anything that you're unaware of that might mean that you shouldn't be taking them. If they're not effective or not effective enough, then you can go into the stronger pain-killing drugs, things like your cocodamols, dihydrocodeines, tramadols, and even some forms of morphine actually. So we're getting into much, much stronger drugs, and obviously they've got higher side effects. They're quite addictive, some of the drugs, and actually over time they stop working as well if you're on them for a long period of time. So what you'll probably hear us saying a lot with these medications is their short-term use. We're using them to control flare-ups, not necessarily to control symptoms every single day. If we are having problems every single day and none of the painkillers are working well, then if it's your arthritic knee, for example, then a steroid injection might help. But it's right at the top of the pyramid because it is an injection. It's a substance getting injected into your body, which brings additional risks like infection, for example. So it is quite high up in the pyramid. But I'll repeat again, with any medications, because we're not doctors as physios and we're not pharmacists, we can't recommend them. All we can do is give you this overview. And if you think any of these levels would help, then speak to your pharmacist or GP so you can get some further advice on what to take. But if we go back to steroid injections for a minute, steroid injections can be carried out not just by doctors and surgeons, but some physiotherapists do them as well. in your GP practice or in the physio departments, and they're an option that's worth considering if you're suitable for it. So we call it corticosteroid injection, but most people know them as cortisone shots. And what it is a strong anti-inflammatory drug. It's injected straight into the joint that's causing the problem, and it's normally very effective, but it is a temporary reduction in pain. So once the steroid kind of wears off and leaves your system, then the anti-inflammatory effect it gives might last for months and months and months. So you might get very good long-term relief, but if the flare starts happening again once the drug's worn off, then it can be relatively short-lived. So it's most helpful during more severe flare-ups rather than kind of low-level grumbling pains. It's normally the ones that aren't responding to the medication that we certainly would think about injecting. It's also worth noting that injections aren't a cure. They might, as I said before, they might help give you some long-term relief if your body reacts well to it, but they don't cure the problem. The problem, if we use arthritis as the example we were discussing today, is that the wearing in the joint has happened, and so inflammation will probably be intermittent in the following years. So injections should be used sparingly, and due to side effects, you can't have that many done. So we usually do a maximum of 2 a year in a knee joint, for example. And the reason is because they can affect the bone quality if you do far too many injections. So we'd be worried about causing other problems by injecting you too much. Some joints, like the hip, for example, actually can't be injected in a clinical setting. So actually, what needs to happen is almost being injected in an operating theatre under sterile conditions. So hips are a lot more difficult to get a routine injection in compared to a knee. They're much more accessible, easy for us to clean, and then easy for us to inject. But please bear in mind as well that some people just actually can't have steroid injections. So even though it might be an option that looks appealing to you, it does depend, much like the drugs, on your personal circumstance. So let's say you are epileptic and take medications for your epilepsy. Some of those medications the steroid interacts with, so we need to be very careful. Other people who we need to be careful with are people who suffer diabetes, because diabetes, obviously your blood sugars can sometimes be too high, and if they are, steroid is known to spike and change your blood sugar levels, and it can be unsafe to do that. So there are people who sometimes we can't inject steroid with, but it is worth discussing this with your physio or your GP if you think one might benefit you, and then they can go through the process of looking at your history to see whether or not it would. So, what else can help improve the situation? Well, first thing I would say is if you want to take a wee break, please feel free to pause the video. I know it's a slightly longer presentation, but it's just to try and get as much information to you as possible. But if you're happy to continue watching, then that's perfect. So what else can we do to improve the situation? Well, exercise clearly as a physio. I'm going to say that exercise is the thing that I would recommend. So it is an essential part of recovering from an arthritic joint pain. It's a common misconception that it's going to damage the joints. In very rare cases it might, but the vast majority of exercise, when it's done safe and it's done guided through a physio or a exercise professional, then actually the opposite is true. There's so much evidence out there to say that it guards your joints and it makes them less likely to suffer longer term damage. Now, exercise is key, not just if we're mild forms of arthritis. Even if you think you're too far gone and you're waiting on your knee replacement or your hip replacement, they are still absolutely key times to exercise. Because if we're waiting for surgery, then it can play a huge part in our recovery, and I can't stress that enough. So I've had people before go in for knee replacement surgeries, for example, where they kind of just counted down the weeks until they went in for the surgery, hoping that once they had that operation, the knee would feel great. They've gone in for the surgery, the knee's been operated on, the arthritic bits have been removed, and then 3 4 months down the line they're still in a lot of pain. And the reason was usually because, one, it does take time to recover from surgery, but second of all, the strength was so poor before the operation. The operation doesn't change the strength, so it just changes the arthritic lining of the joint by giving you a new joint. So if you're sore and you're waiting for a joint replacement, then we would say exercise is absolutely essential to strengthen up before you go in. Plus, if you're very good at your exercises before you go in, then when the physios in the ward come round to terrorise you, you'll already be good at them. So you even less of an issue there. There's so many exercises available. Some are more advanced than others depending on your capability. So the key I have, and it's underlined here for everyone, is to know your limits and stay comfortable. Don't cause a flare up. There's no need. You can stay comfortable through exercises that were specifically tried and tested by you. And, I always use the example of you don't need to go to a spin class to strengthen your legs. And in fact, most people with arthritic knees, if they went to a spin class, they would get a shock. It's starting off easier than that and then building your way up. And there's nothing to say you might not make it to a spin class later on. But most importantly, enjoy it. You need to enjoy the exercise you're doing, or it's only a matter of time before it falls by the wayside. So please choose something that you don't mind doing, and that could be a wee exercise program in the house. It could be a walking group. It could be a set of pedals that you've bought online that you sit in your sofa and cycle away. There's tons and tons of stuff that you can do, but you need to enjoy it and not mind doing it. Now, various types of exercise, as I've already said, so they kind of split up into categories. Aerobic exercise is your walking, cycling, swimming, cross training, that type of thing, rowing. Strengthening is equally as good as aerobic exercise. It's been shown, and that the kind of category that would be things like gym machines if you did go to a gym, free weights, so ankle weights or dumbbells, things like that. The home exercise programs that we give you in physiotherapy, they tend to be strengthening exercises. So that's the kind of options that you have. Now, how often should we exercise? I suppose that's another key question. Well, the Scottish Government and the UK Government have both said basically 150 minutes a week of moderate exercise. So moderate exercise we normally term as exercise that gets you a little bit out of breath. So it doesn't need to be absolutely hell for leather, but it needs to be a little bit more than just a wee brisk walk, although brisk walks are absolutely fine as well. But we normally want to push it a wee bit more than that. So that could be split up in any way you want. So you could do 2 hour long exercise sessions, and that would be 4 of your 5 days a week if you think about it that way, because that's 2 lots of 30 minutes, which is 2 days. So actually in 2 hour long exercise sessions twice a week, you've already done 4 out of your 5 days worth. And within that day, if you can't do 30 minutes of exercise because you're too sore, you could break it up into 3 10-minute walks. Or a 20-minute kind of mild exercise video and then a 10-minute walk. So you can break it down any way you want, but the 150 minutes is kind of seen as the gold standard we should all be aiming for. What exercise is best? I quite often get asked that question. Well, whatever works. And that's really it, because there's no evidence to say that one type of exercise is better than others. There's lots of evidence for walking being good for arthritis, but in terms of other studies have shown that strengthening is also very good for it. So really, it's not too much of an issue. They're all good at reducing pain and arthritis as long as we do enough of them. So make sure you enjoy it, and that makes you more likely to do it longer term. So in terms of resources available for exercise in the Forth Valley area, things are a bit up in the air at the moment just because coronavirus has stopped a lot of the gym classes and sessions. I'll outline what we had in all 3 regions, Clackmannanshire, Stirling and Falkirk, because our hope is obviously they'll return to their pre-COVID levels as soon as things have settled down. However, we have recorded a number of exercise classes in video form, and we're hosting them on YouTube. So at the end of this video I'll share some links with you so that you can go to YouTube and you can see Clackmannanshire very own Kenny Cook, who works for Clackmannanshire Sports Development, who helped film one of his classes for us so that we could offer that option to people who can't get out just now or can't get to a gym or a club where we used to run the classes. So hopefully you'll find the resources very useful, and you can do the online ones from the comfort of your own home, which is useful as well. So these are the options that I was speaking about before that were available across the Forth Valley region, and we are hopeful, as I said, that we will get back to these as soon as possible, but because we don't know when that will be, We'll outline them just now, and we'll keep our eyes open, and hopefully they'll be back soon. So Kenny, who kindly filmed the class for us to put online, he covers active clacks in the clack manager area. So there were three different classes actually. There was two in the Cochrane Hall in Alva, and there was one in the Beaumar Centre in Alloa, and they ran in 2 different days of the week. The Active Fourth programme covered the Falkirk area with two classes in Grangemouth in the sports complex there, and Active Stirling also got involved kindly to cover a couple of classes for us in the Stirling region. One was in Fintry, and the other one was in the Raploch campus for Forth Valley College. So we had quite good coverage across Forth Valley for this specific class for arthritis, but there are other options available as well. So as well as Kenny's lower limb class that he's filmed for us, NHS Forth Valley Physio Department, we also filmed our own classes and host them, as we said before, on the YouTube channel. If you go to YouTube and type in NHS Forth Valley Return to Fitness, that's where you'll find the playlist. And the Return to Fitness program is designed for people recovering from a host of different musculoskeletal conditions, so not necessarily just arthritis, but you might find that if you're getting better and better at the exercise class that Kenny runs, you might enjoy some of the ones run by the physio department. So please feel free to go on YouTube and have a look at them as well. They also include a relaxation session, which is quite nice just to kind of unwind and de-stress and can help with pain. Other options, when Active Fourth and Active Stirling start up again, you can actually become a member of either and have access to the gym, swimming pool, fitness classes if our classes are getting too easy. Active Clacks have various other classes in the region as well, and we'll put a link to their website at the end of this. You can get access to school gym facilities to do exercise as well. So there's lots and lots of options within here. If you're interested in getting referred to Active Fourth, Active Stirling, then they are schemes that any health professional can forward you to for any health condition, essentially. So things like heart problems, diabetes, arthritis. If you've injured yourself post-injury, you can get a membership to these places. So you can see their websites for details on the costs involved, and obviously just monitor that for when they open again. What if you don't want to go to a gym or a class? Well, I think it's important to add that you can do all this stuff yourself. So gyms just aren't always for people, and some folk just don't like them, and that's absolutely fine. Same with classes. People don't love class environments sometimes, and that's totally fine, whereas other people really benefit from that environment. So it's important that you choose. Walking's a fantastic way of keeping fit. So we've got the Braveheart walking group, we've got the Step Forth, which is Falkirk's version, that is run by the kind of Active Forth scheme. Walkabout Stirling, which is the Active Stirling. Paths for All. We've got so many beautiful walks in this country, and a lot of them in the Forth Valley region actually. So walking is a really, really good way to get healthy, to get fitter, and to not feel the pressure to be in a gym or a class. You could also try other things, and this isn't meant to be patronising the slightest. These are facts that if you try parking further away from the entrance to the shops, get off the bus stop one early, walk an extra couple of flights of stairs a day, is climbing Ben Nevis over a year. I was quite impressed with that one. You could use walking poles or hiking poles when you're out walking to try and allow you to go further with more comfort. So there's various ways of making yourself more prepared and ready to exercise and then to take part as well. And what if you're not sure? So I've talked here lots and lots and lots about exercise and why it's fantastic. Now, if you're not sure, that's fine, absolutely fine. Some people need to take their time and think about it. Some people need to plan a bit more. I would advise you to go and watch this video if you're not sure. It's an American doctor called Mike Evans. It's called 23.5 hours. The link doesn't come up very well in this presentation. There's lots of digits and numbers and things. So if you just go to YouTube and type in 23.5 hours, you'll get this chap's playlist coming up. There's tons of videos on lots of different health problems. So if you notice any other ones you're interested in, like diabetes or things, and he does videos on that as well, and they're great. But this one is the one we're interested in the most, 23.5 hours. And it's done in like the cartoon format where there's a hand drawing the cartoon while doing the voiceover. It's a nice interactive way of learning. And in essence, what he's saying is that for 23.5 hours of the day, if we do absolutely nothing, then as long as we do 30 minutes of moderate exercise, our risk of things like stroke, heart disease, arthritis, and so on are usually at least halved, sometimes more. So exercise, even small amounts of it, can be so beneficial. So have we watched this video? If you click the YouTube link in the presentation, it should take you to it. If you want to watch it afterwards, totally fine. It's about 8 minutes long, the video, so the first 3 minutes have a lot of the information you would need, but it's very good. So we've talked a lot about exercise, but what about the role of a balanced diet with joint pain? So, quite often diet and its effects on the body, aren't as obvious to people as contributors when you compare them with things like exercise. But good control and knowledge about a balanced diet can go hand in hand with exercise as an essential component to help reduce your joint pain. They're not standalone things. They integrate very closely, and having more nutrients in the body and a diet that maintains a good weight can help contribute greatly to improving joint pain. As you've noticed, I'm not a dietitian, and although as physios we have a specialist interest in diet and in general advice on how to maintain your well-being, it would seem appropriate to pass on to one of my colleagues, Emily Holt, who is one of our community dietitians, who's kindly agreed to give us a quick overview of what a balanced diet looks like using the Eat Well guide.
Thanks, Peter. You're absolutely right. A balanced diet is something that we try to promote for everyone, but there are specific benefits when it comes to osteoarthritis. One of the most important relationships between diet and osteoarthritis is weight. As Peter has already mentioned, being overweight increases the strain on your joints. There's strong evidence that losing weight can reduce pain and improve physical function and mobility. If you are overweight, losing 10% of your body weight will give optimum benefit, not only for symptoms but for overall health. This can be achieved by eating a healthy, balanced diet. And if you're not overweight, following the advice below is still beneficial. So the Eat Well guide on this slide helps to show the proportion of different food groups required to achieve a balanced diet. The yellow section represents potatoes, bread, rice, pasta, and other starchy carbohydrates. Carbohydrates are an important source of fuel, which we need for energy. It's helpful to choose whole grain starchy carbohydrates because they contain fibre, which can help keep you fuller for longer, which in turn may help you to eat less throughout the day. Examples include wholemeal or whole grain options, and even going for 50-50 varieties are great alternatives. The green section is fruit and vegetables. We're all advised to aim for 5 portions of fruit and veg every day, and this is because fruit and veg are packed with vitamins, minerals and fibre, which help to promote overall health and they're relatively low in calories. All types count, including fresh, frozen or tinned. If you struggle to meet your 5 a day, some tips include blending or grating vegetables into sauces or soups or snacking on a piece of fruit. Next is the pink portion, protein. We need protein for muscle growth and repair. Proteins found in meat, fish, eggs, as well as plant sources such as beans and pulses. The Eat Well guide advises to try to increase our intake of beans and pulses, and examples include lentils, chickpeas, baked beans, kidney beans, to name a few. And it's because they're lower in fat, they're higher in fibre, and they actually count as one of your 5 a day. One easy way to incorporate more is to add them to your meal staples, such as chili, bolognese, curry, stews, or in soups. The blue section represents dairy and alternatives. Again, these provide us with protein as well as calcium, which is essential for bone health. Opting for lower fat and lower sugar options can help you to save calories. Did you know that the portion size for cheese is the same size as a small matchbox? One way to use less is to opt for stronger cheese to get more flavour, and grating instead of slicing cheese can make a little go a lot further. The last section in purple is the oils and spreads, and these are the smallest portion of the guide because oils and spreads are made of fat, with 1 gram of fat containing 9 calories, compared with protein and carbohydrates, which have 4 calories for every gram. We do still need fat in small amounts because they help with vitamin absorption. However, opting for unsaturated oils such as olive oil or rapeseed oil and using in smaller amounts can help to improve your heart health. There's one last group we haven't discussed yet, and that's the highly processed foods, which are often very high in calories as well as fat, salt and or sugar. Examples include crisps, biscuits, chocolate, cake, pastries, pies and ice cream. You may notice these aren't included with the rest of the food groups, and that's because these foods are not essential to our health. They provide no additional nutritional value, and so we could live and function without them. They are, however, something that's enjoyable, and that's why it's advised to eat these less often and in small amounts. The Eat Well Guide, it's not a fad diet, it's a balanced diet to be sustained for life, which is why no foods are restricted or forbidden. It can be difficult to cut out foods completely, and so looking at what you already include in your diet and identifying some small changes can make all the difference. For example, if you eat a packet of crisps every day, could you eat a packet of crisps every other day and have a piece of fruit instead? These small, simple changes to your everyday intake can have a huge impact on not only your weight but your overall health. One last tip is on vitamin D. Vitamin D is essential for bone and cartilage health. In winter months, the majority of people living in the UK aren't getting enough vitamin D because the primary source is from sunlight, which, as we know in Scotland, can be limited. Taking a vitamin D supplement daily, between 10 to 25 micrograms a day, especially during the winter months, will help to ensure you're getting enough vitamin D throughout the year. So that was a quick overview of what we mean when we talk about a healthy, balanced diet. So I hope some of that was useful to you. I'll pass you back over to Peter, who's got details of extra support available if you are looking to lose weight, as well as some great resources.
If you feel that you need more support with your diet, there's lots and lots of resources online that are available. So NHS Fourth Valley is a fantastic Choose to Lose service, which is free to access, and it's just a website. They've actually done their video similar to this one on YouTube as well. There's the link there where they can guide you through the Choose to Lose process. It's a no strings attached informative video that just gives you an overview of how to manage your diet a bit better. Because the hard bit about losing weight is keeping the weight off. Usually, if most people put their minds to it over the first week or two, you lose a decent amount of weight if you try. It's the long term that's the hard bit. So some fantastic guidance and Choose to Lose that I would really recommend that you try. You can obviously do commercial weight loss clubs. Can't name any of them, but you'll know who they are. There's plenty of them out there. There's mobile phone apps. Can help motivate and track your what you've taken in, and track your diet. So if you feel you're struggling with your weight, then if you're not ready to interact and not ready to talk about it, then don't worry about it. But have a think about it yourself. And if you decide that you would like some input from the dietitians in Forth Valley, then ask your GP or health professional to refer you to them for some advice. So set goals, have a plan. That's my best advice to you. Lifestyle change is a lot easier if it's well structured and well thought out. If we decide on a Friday that we're going to go on a diet on a Saturday, usually doesn't last for very long because there's no thought and planning going into it. So plan when you could start, plan what exercise you were able to do. Is there anyone that can go with you? Any friends you can rope in to exercise with you and make it more fun? Make your goals realistic and achievable, and make them important to you. So if an important thing to you is to be able to walk around the shops without hanging onto the trolley for dear life, that's a good goal. And that's a measurable one. That's one that you could then go to the shops in a couple of months after starting your exercise and say, do you know what? I'm walking around the shops much better. So make realistic goals of things that you want to achieve. You can use fitness trackers, smartwatches, mobiles, use them as motivation as well. Very quickly, non-medical things that help. Well, thermal treatments, so ice and heat. Heat's probably the one that we go to first for arthritis because it tends to soothe and comfort the knee. But when you have a flare up and the knee's a bit swollen and maybe a wee bit warm, ice is actually really good. So, bag of ice wrapped in a tea towel, that could be really good for settling down the inflammation. TENS machines, you're more than welcome to try. It's an electrical signal that kind of interrupts the pain signal. That's the plan. Tries to confuse the pain so that you don't experience it as badly. You can usually wear them on your belt or put them in your pocket, and the wee pads stick to the surrounding areas and kind of give that kind of tingly feeling. So they sell them online in most chemists now, very cheap. So if you wanted to try them, you can. As I said before, walking aids or hiking poles are fantastic for getting around. They can take pressure off the sore side. So every time you put your sore leg down, you dig the poles in and take some pressure off. It can help you walk further. Footwear, if you've got nice supportive footwear or trainers or insoles, then that can be really useful. It takes some of the shock away from when your foot hits the ground. But also things like knee braces. So if you're not fit for surgery or can't have surgery or don't want surgery or you don't want injections, sometimes you can go for a wee knee support that you can wear when you're out walking, and that can just keep the knee a bit more snug We would just normally say don't wear them if you're in the house resting because a knee support is very good at doing the job of the muscle for you. So if you wear them far too much, then your wee muscles will get thinner instead of stronger. So only wear them when you're exercising or when you're on your feet for longer periods. So this slide goes through a question I get asked quite often actually. Can you use other treatments for arthritis like complementary therapy? So that's what this slide depicts. And the short answer is yes. You know, you can use any kind of complementary therapy or holistic homeopathic treatments as you see fit. And I think the important thing is to determine, you know, do they work for you? Because if they do, then there's absolutely no reason why you can't. The reason why we don't necessarily recommend many of them is quite simple, really. The kind of nice guidelines, the guidelines that research effectiveness aren't terribly clear on a lot of these things, and that there's not been enough research done for several of them to really guide us in their effectiveness. So some people might say they work particularly well for them, but then you might get a large number of people who they don't work for, and so it's quite hard to recommend them if we don't have that, I suppose, that example of their effectiveness in a clinical setting. So examples would be things like acupuncture, reflexology, so very popular, kind of holistic therapies, but the research isn't there, but you know, we will get patients to say they work really, really well for them. So I think if you want to try things like that, you know, the spices like your turmeric capsules, cod liver oil, fish oils, chondroitin, glucosamine, or even rubbing the joints with things like lavender oil, stuff like that, then absolutely you're more than entitled to go for it. And if it works, perfect. But we can't recommend them openly just because, as I say, we're not terribly sure in the effectiveness of a lot of them. So you'll be glad to know that we're almost finished the presentation, but it's important to cover the question of, well, what if you're not coping, and what if all the interventions we've discussed so far haven't worked or aren't working for you, and your pain's not controlled? Well, like I said at the beginning of the presentation, arthritis can be very stable for many, many years and not really give people that many kind of severe or major issues. Um, but we also know that it is a condition that can get worse. And so people could be fine now, but they might have issues later. So that's why we don't really shy away from the word surgery, because although a significant percentage of patients with osteoarthritis will never need a joint replacement, we know there are a few cases and a smaller percentage of people who actually might get more severe and therefore might need surgery. So if that was the case, we prefer people to be over 65, and it's nothing really to do with money and funding. It's more to do with the fact that we reckon there is a shelf life on the joints. We need to remember they're not made of bone, and they weren't designed specifically for you, so only your bone was designed to be in your body. The joints that we replace your bone with are all kind of standard sizes in a catalogue, so they're not designed specifically for your knee, and they're made of plastic and metal usually, so so they have a shelf life, and as I say, we reckon it's about 15 years. So there are people out there who might have had their knee replacement or hip replacement for 30 years, so it's not a dead cert, but if it was 15 years on average, then it means that if it gets done very young, then the problem can be that we sometimes need to replace it again. And obviously each time you go in and take out a joint that's been cemented in and replace it, it can cause more trauma and more damage to the bones. And so, if at all possible, we prefer to do these surgeries once so you get good use out of them, but then never have to get them done again. It is important to stress again, however, that even if surgery is the option and you're awaiting surgery, you're on a waiting list, the surgeons would absolutely back me up here when we say we need to strengthen the legs, even if it's uncomfortable and sore to exercise. That makes it more important to do them so that the joints are strong, the muscles are strong, and it prepares you to recover from an operation, because it's not a small undertaking, it's quite a big operation and there is trauma involved. So we say definitely make sure you're strong, make sure you're prepared for the operation, and you should manage absolutely fine. But if you go in underprepared, then you can have issues. If you'd wondered what a knee replacement looks like and you haven't seen one before, then these couple of pictures are quite good to demonstrate it. So the X-ray on the left shows you kind of where the pieces go, if you like. So the arthritic bone is removed from the end of the thigh bone and the top of the shin bone, and effectively the new joint's kind of plugged in. Sometimes they do replace the kneecap if it's severely affected, but actually quite often you'll notice in the x-ray to the left, the kneecap's the original one. So a lot of the time the kneecap's fine, so they just leave it. But on the right hand picture you can see an example of them replacing the undersurface of the kneecap. And this is the hip replacement. So looks a wee bit more drastic on the x-ray, but it's just because the metalwork has to go further down into your thigh bone just to remain stable. So just like the knee, sometimes they don't replace all the bits. So if your socket's absolutely fine, then they don't replace the socket, they just replace the ball, and then they have the bit that goes down into your thigh. But sometimes if the socket's quite worn and your labrum's kind of worn the cartilage in the socket, then they'll give you the artificial socket as well. Interesting to note that sometimes after a hip replacement, your leg can be a wee bit shorter as well. So if you've ever noticed that, if you're watching this and you have had a hip replacement before and you kind of limp ever so slightly, sometimes it's because the leg's actually a bit shorter. And a wee insole or a heel raise can correct that. So if you're concerned about anything like that happening at all, or it's happened to you, you can get in touch with the physio department if you need to get a referral to us, because we can usually recommend on what to do to correct that. So you'll be glad to know that that's the presentation pretty much finished, and thank you very much for sitting through it and listening. Hope you found it useful, and I think that's the main reason why we've run these sessions in the past, because there's various people have said to me at the end of them when we did them in person that they genuinely didn't know a lot of the stuff that we went through, and it's made them a bit more confident, a bit more able to exercise without that kind of fear, and also a bit more aware of what their options are going forward. So hopefully now you can use the kind of information we've discussed in this session, along with the links that are about to come in the next few slides, to the exercise and stress management and things like that. You can use all of that information to try and manage your joint problems well. And if you have any questions that we didn't cover in this, and I completely appreciate that if you're in a lot of pain sitting through this video, then that there might be things that you would want to ask that you weren't able to because it's done online. I'm happy for you to email the email address at the bottom of this slide if you've got any specific questions, and we'll do our very best to answer them as far as we can. So hopefully you found it all useful, and it gave you some food for thought. I'm going to leave the following few slides on for a minute or so each, because these are the resources that I talked about before and the links to those resources. So of course you can pause the video as well and you can note them down, or you can visit these websites on your computer, tablet or phone. But I'll pause at each one just to give you time to have a look through. So this slide has the resources for pain management and any mental health concerns. And this slide has the resources available for weight management and well-being. This slide has the resources available for exercise, whether it's mobile apps or websites, or of course our YouTube channel. This slide is another reminder of our lower limb exercise classes across the Forth Valley region that we're hoping very much are up and running again soon. And here's another reminder in the meantime of our online exercise classes on youtube.com. Please feel free to go online and have a go at these classes as well. Sometimes there are adverts in the middle of them because it's on YouTube, but in the bottom right corner you can click skip advert and it will continue on with the class. So thank you very much for listening again to this talk today. Hopefully you found it very informative. If you have any questions, please remember to get in touch and we'll try and answer them as quickly as we can. But on a more important note, hopefully you keep healthy, exercise to the best of your ability, even if it's low level, and with any luck, you'll see improvements soon. But please get in touch if you have any other questions. Thank you.